All right, so we have the last presenter of this session, Dr. SHAIFALI CHAHAR, and she's a fellow at CFS and a very good friend. All right, so she's going to speak on outcome of radiofrequency vaporization in conjunctival venous malformation. Over to you.
Thank you, ma'am. At the outset, I would like to thank AIOS Scientific Committee and my mentor for this opportunity. Good morning to everyone. So my title is Into Thin Air, which is the effect of radiofrequency vaporization for a case of conjunctival venous malformation. A 32-year-old lady presented to us with a right eye lower eyelid swelling, which was present in her for the period of 4 to 5 years. And she typically gave a history of increasing of the swelling size on bending. There was no history of trauma, recent viral illness, pain, diminution of vision that was noted in her. This is what we saw when we everted the lower lid. Past history, no ocular or systemic history was relevant. On examination, as you can see here, there was fullness noted in the right lower lid, which was soft, non-tender, bluish-black swelling, which was non-mobile. On eversion of the lower lid, the lower tarsal conjunctiva, there was a violaceous, soft mass, non-tender, non-mobile with dilated blood vessels, which was typically increasing on Valsalva maneuver and post-bending. There was no proptosis that was seen in this case, and the ocular motility was free and full. Rest of the ocular examination, as you can see here, was within normal limits. So the provisional clinical diagnosis at this stage was a conjunctival varix, but at this point it was important to rule out any orbital component of this varix. So we went ahead with the radiology, and CT scan showed an extension to the extracorneal space in the inferior orbit. And also on CT, that is radiology, there was an increase in the size that was seen post-Valsalva maneuver. So the clinical radiological diagnosis that we made was conjunctival varix with an anterior orbital extension. The management that was planned for her was injection bleomycin that was given for the orbital component, but for the tarsal component, we decided to go ahead with a radiofrequency ablation. This is her at 1 month follow-up. As you can see, the tarsal conjunctival component has beautifully resolved after the radiofrequency vaporization, but there's a small residual lower lid fullness that still remains, for which she was given another injection of bleomycin at this stage. She was stable for 4 months, and a repeat injection and a radiofrequency ablation was done after 4 months. And this is her at her 8 months follow-up after the last visit. And as you can see, the tarsal conjunctival component has beautifully resolved, and there's no residual component that remains there. So just very quickly to touch upon the radiofrequency vaporization, we use no financial disclosures, but what we used was the Elman unit. A10 electrode is used, 4 megahertz dual frequency surgical suit, and keeping at the coagulation mode of 6 to 24. The body of the probe has to be kept very parallel to the tumor surface, and it just fulgurates the tissue. The power that is used is to maximize vaporization, and it minimizes charring. So how it works is high frequency radio wave on the subconjunctival tissue. It just coagulates by the local burns to the tissue because of the friction of the water molecules by the conversion of radio waves that is used into heat, and it just fulgurates. And for the surface component of the varix, it is an excellent option because surgery, obviously, we all know is difficult. Bleomycin can be used, but then there can be scarring or problems with that. But this can provide excellent cosmesis for the patient. So in conclusion, there's no bleeding, there's less surface scarring, it avoids damage to the normal tissue, maintains structural and functional integrity of the lid. There's no need for any reconstructive secondary procedure. There's quick recovery, early recovery, and less morbidity. Hence, use of the radio frequency really turned it into thin air and gave magical results to us. Thank you so much for your patient listening.
Yeah, thank you, Dr. SHAIFALI. Excellent presentation. One quick question to you. So you did combine bleomycin
Yes,
with it, yeah.
Yeah.
So do you want to give the credit to the radiofrequency alone, or you want to give credit to both the combination therapy here?
Ma'am, combination therapy, because here the orbital component was also there, but in some cases where only surface component is present, we have used only radiofrequency, and it has worked very well. Even on like eyelid nevus and all, I've seen sir using it, so it just vaporizes the entire tissue.
All right, so here you would give credit to both?
Both.
Credit to both. All right. Now you just mentioned that bleomycin causes scarring in the last sentence that you said.
Not so much of scarring, ma'am, but like the injection per se, it will not totally vanish away the lesion how it was seen in the vaporization, like in the cases that I've seen. The injection, the bleomycin injection, the ocular surface, especially the bulbar surface, some amount of scarring remains after the bleomycin.
You think so?
Mm.
I don't think so, actually, bleomycin, yeah. So bleomycin is a drug which just goes and, closes the vascular channels, right? Yeah, we don't find much of scarring with bleomycin. So how many settings of radiofrequency cautery did you use in this?
Two settings, ma'am.
Two sessions.
Two sessions.
And both the sessions you injected bleomycin along with it?
Yeah, ma'am. In
Both
the first one also and the second one
both
also.
The sessions, all
because
right.
The lower lid component still remained even in the second session when it came back.
All
so
right.
bleomycin was used even in the second session.
Yeah, so it would have been really nice if we saw something which was only radioablated, right? Yeah, okay.
Yeah.
Thank you.
Thank you, ma'am.
Very nice presentation.
Thank you, ma'am.
But I have used bleomycin for many of my cases, even for conjunctival lymphangioma. And the concept of bleomycin is basically it collapses the lymphatic system. It works more on the lymphatics. So I have not come across any scarring. To be very frank, I have done a good number of cases and published also with Dr. Guy Ben. There was a very big publication, 22 cases or something. So I have not encountered any, because it works more on the lymphatics, right? It collapses, shrinks the lymphatic. That is how it is working. But this is a very nice option, and I have seen before also very nicely documented. Maybe the surface it is working good, but still we need to prove it by biopsy or this whether actual scarring is happening or not.
Yeah.
Whether it's just a scar or the
remains.
immediate contracture of the lymphatics that you are saying.
Just one quick comment. You showed that the lesion recurred and you had to go in again.
Yeah.
That is something
Yes,
we
sir.
need to explain to patients.
Yes,
Despite
sir.
our best efforts, it may recur.
It
and
may
we need
recur.
to-
Yes, sir. True,
Okay.
sir.
Yeah. Thank you.
Thank you so much.